None po? Okay, again, important concepts to remember. Libihin ko lang po yung development of reproductive system. Baka medyo choppy po ako kanina. Again, when you say mesonephric duct, you associate it with male or female? Male. What is the other name for mesonephric duct? Wolffian duct. Okay, very good. When you say, sorry, paramesonephric or Mullerian duct, we associate it with female. Okay, paramesonephric is Mullerian. Okay, again, basic concepts to remember. If the mesonephric duct will develop, the paramesonephric duct normally should regress, and vice versa. If the paramesonephric duct will develop, the mesonephric duct should regress. Okay, so again, what will cause development of mesonephric duct or Wolffian duct? What is the answer?
Presence of testosterone.
Very good, presence of testosterone. Okay, what will cause, okay, regression of the paramesonephric duct? What will cause regression of the paramesonephric duct? Section B, presence of anti-Mullerian hormone. Okay, and the other way around, what will cause regression of mesonephric duct? The answer should be absence of testosterone. Okay, tama. And what will cause development of paramesonephric duct? The absence of anti-Mullerian hormone. Okay, are we clear po? Okay, again, we did mention during the lecture the derivatives of mesonephric and paramesonephric ducts. Okay, for sure we're going to ask you that. So go back to those concepts. Okay, lastly, what will cause, okay, development of the gonad, sexual differentiation, the presence or absence of TDF. The presence or absence of TDF. Again, basic concepts to remember. If there will be TDF, okay, there will be development of internal and external genitalia of male reproductive system. In the absence of TDF, there will be development of external and internal genitalia of female. Clear? And TDF is present only on the Y chromosome, SRY gene of the Y chromosome. So are we clear po? Any questions?
No questions po.
Okay, so let's proceed now with development of the endocrine system. Again, if medyo choppy po, sabihin niyo lang po sa akin. Ha? Okay, this will be the objectives for this lecture. We're going to discuss the development of important endocrine glands, thyroid, parathyroid, pituitary gland, adrenal, and pancreas. The development of the male gonad testis and the female gonad ovary already mentioned during the previous lecture. And we're going to discuss common congenital anomalies resulting from abnormal development of the endocrine glands or endocrine system. So let's start with the organ. Wala po yung cursor ko. Okay, thyroid gland. Okay, thyroid and parathyroid gland. Okay, in gross anatomy, it will be mentioned the specific location of the thyroid gland. Okay, in the neck area, anterior part of the neck area. Okay, this is a thyroid gland which is made up of right and left lobes connected together. At the center, isthmus. Okay, and behind thyroid gland, important endocrine gland to remember will be the parathyroid glands, which is related on the posterior part of the thyroid gland. So let's start with thyroid. Okay, thyroid gland is said to be the first endocrine gland to develop approximately 24 days after fertilization. Okay, and the germ layer of origin is coming from endoderm. There will be thickening in the floor of the primordial forix, and that is coming from endoderm germ layer, and it will form a small outpouching. We call it as diverticulum. Okay, before I proceed, I want you to make a tabulation for you to easily remember this topic. I want you to make a tabulation. Okay, first you have to write the gland, endocrine gland, and then take note of the origin, embryonic structure, germ layer of origin, and then last column, congenital anomaly to remember. So make a tabulation, okay? Again, gland, origin, embryonic structure to remember, and congenital anomaly. So first gland to remember, thyroid gland, okay? Coming from endoderm, I want you to remember the embryonic term thyroid diverticulum. Diverticulum is an outpouching coming from the primordial forix endoderm germ layer. Okay, so in this picture, so on the primordial forix here, you're going to have an outpouching, and we call it as the thyroid diverticulum. So the endoderm will start to evacuate, okay, to form the thyroid diverticulum, starting at week 4, okay? And after that, so there will be formation of this structure. We call it as your thyroglossal duct. Thyroglossal duct, referring to glossal tongue, and thyro, the developing thyroid gland. So what will happen? The thyroglossal duct will start to descend. Okay, you have the thyroid diverticulum forming the thyroglossal duct, and the thyroglossal duct will start to descend towards the neck area. Okay, at week 7, the developing thyroid gland, okay, will reach its final position, its final location position in the neck area. So those are important concepts to remember. Okay, with the growth of the embryo in the tongue, the developing thyroid gland will start to descend in the neck. Initially, the developing thyroid gland is connected to the tongue by a narrow tube. We call it as your thyroglossal duct. By 7 weeks, okay, the developing thyroid gland will assume its definitive shape and reach final site in the neck area. Okay, so what will happen to the thyroglossal duct? The thyroglossal duct normally will degenerate, okay? And the proximal part, you have a remnant, and that remnant, we call it as the foramen cecum of the tongue. Okay, let's go back to this picture. I hope you still remember the picture of the tongue. This is the sulcus terminalis, a V shape that will separate the tongue into an oral part here and pharyngeal part posterior. The foramen cecum is located here, anterior to the sulcus terminalis. Again, frequently asked in the board exam, the foramen cecum represents the remnant of what fetal structure? Thyroglossal duct. So here's a picture again to show you the formation of your thyroid diverticulum, okay, that will form the thyroglossal duct, and the thyroglossal duct again will start to descend into the neck area. After descent, okay, the thyroglossal duct again will degenerate, and what will be left is the foramen cecum. Okay, it was mentioned during the lecture and the orientation that the unit structure of the thyroid gland, we call it as the thyroid follicle. Okay, you should take note that the thyroid follicle formed during the 11th week of development. Okay, I want you to remember that. Congenital anomaly to remember. Okay, Thyroglossal duct, again, normally will atrophy and disappear, but sometimes it may persist to form a thyroglossal duct cyst. It is characterized as a painless, progressively enlarging movable mass. It is usually asymptomatic unless it becomes infected. Following infection, what will happen? There could be perforation of the skin, and this could lead to formation of a thyroglossal duct sinus. Okay, so if you have an opening, formation of an opening, okay, into the surface, and this is seen usually after infection, we call it as a thyroglossal duct sinus. Okay, here's a picture that will help you to remember that. In children, if you see a mass, a movable mass at the neck area, before you think of an enlarged thyroid gland, you have to rule out the possibility that this might be a case of a thyroglossal duct cyst. Okay, and the thyroglossal duct cyst is seen anywhere in the course, in the descent of the thyroid gland. Thyroglossal duct cyst. So again here, showing you thyroglossal duct cyst. Okay, and following infection, you're going to have an opening to the outside, to the skin, and that could lead to formation of a thyroglossal duct sinus. Questions so far?
None po.
Okay. So to rule out, again, you should rule out if you see a case of an enlarged, okay, a mass at the neck, especially in children, before you think, okay, in children, before you think of an enlarged thyroid gland, again, you rule out the possibility that this might be a case of a thyroglossal duct cyst. Okay, what will you do? You simply ask your patient to protrude the tongue. Take note, ask the patient to protrude the tongue. Okay, and you will notice that upon protrusion of the tongue, what will happen? The mass will move. What is the reason behind? Because you still have connection between the tongue and the thyroid gland. So ask the patient to protrude the tongue, and you will notice that the mass will move. Okay, when you go to your surgery, it will be discussed. The definitive treatment here is, of course, surgical removal of the thyroglossal duct cyst. Any questions, pa?
None po.
Okay, again, first organ, thyroid gland, endoderm, embryonic term to remember, thyroglossal duct. Okay, and congenital anomaly to remember, thyroglossal duct cyst and thyroglossal duct sinus. The most common location of an ectopic, what is the meaning of ectopic? Whenever you encounter the term ectopic, what does it mean? Ectopic. Ectopic, section B.
Not in the original position.
Very good, okay. And the most common location of ectopic thyroid gland is lingual. Okay, lingual, which means there's failure of descent. Again, ectopic thyroid gland may be seen anywhere from its origin down to its course. And in some cases, the thyroid gland is seen at the sternum, behind sternum, substernal. Substernal thyroid. Okay. So these are anomalies of the thyroid gland. Okay. Agenesis means there's failure of development. Okay. Aberrant is ectopic thyroid gland. Most common location is lingual. And again, the congenital anomaly, thyroglossal duct cyst. Okay, let's go now to parathyroid. Okay, before we discuss parathyroid gland, let's go back to the pharyngeal apparatus. Okay, this was mentioned during your lecture in the development of muscles. Okay, especially the muscles of branchiomedic in origin, derived coming from pharyngeal arches. Okay, pharyngeal apparatus is made up of arches, grooves, and pouches. And for this meeting, I want you to remember pharyngeal pouches. Pouches. Pharyngeal apparatus formed during the 4th to 5th weeks. So this picture will show you again the pharyngeal pouches. Pharyngeal pouches derived coming from endoderm. Take note, huh? This is pouches, endoderm. And these are the pharyngeal pouches to remember. First, second, third, fourth, fifth, okay? Especially for this lecture, I want you to remember the third and the fourth pharyngeal pouches. The third pharyngeal pouch will give rise to the inferior parathyroid gland plus thymus gland, while the fourth pharyngeal pouch will give rise to the superior parathyroid gland. Okay, the fifth pharyngeal pouch, okay, usually will develop initially, but it degenerates and it becomes part of the fourth pharyngeal pouch to form the ultimo bronchial body. We're going to mention the significance later. So parathyroid gland, two numbers to remember, third and fourth pharyngeal pouches. Again, the third pharyngeal pouch will give rise to the inferior parathyroid, while the fourth pharyngeal pouch will give rise to the superior parathyroid. Germ layer of origin, again coming from endoderm. These are congenital malformations to remember regarding parathyroid gland. Okay, normally we have only 4 in number, 4 parathyroid glands, 2 superior and 2 inferior. Okay, 2 on the right lobe, 2 on the left lobe of the thyroid gland. So all in all, we have 4. So when you say accessory or supernumerary, okay, so you have, instead of 4, it could be 6, etc. Okay, absence. Absence means there's failure of formation of parathyroid gland. Ectopic. Ectopic means, again, the position is abnormal. And the most common location, again, it can be seen anywhere within the course, but the most common location is here, thymus gland, together with the thymus gland. Do you still remember your lecture in the mediastinum? The thymus gland normally is located in what part of the mediastinum?
Anterior.
Anterior and superior mediastinum. Okay, so again, the parathyroid gland is seen together with the thymus gland. Okay, when you go to your pediatrics, this syndrome will be mentioned, DiGeorge syndrome. Okay, wherein there is congenital thymic aplasia and absence of parathyroid glands. The reason behind this is there's failure of the third and fourth pharyngeal arches pouches to differentiate. Okay, again, DiGeorge syndrome, there's congenital absence of thymus and parathyroid glands. Okay, the presentations will be discussed when you go to your pediatrics. Okay, so again, here is your some examples of congenital anomalies. So you have here an accessory, okay, parathyroid gland, and again, the most common location is together with thymus gland. So these are ectopic locations. Histology of parathyroid gland, two cells to remember, chip cells and occiput cells. The chip cells, take note, will differentiate during embryonic period. And it was mentioned during your orientation, the chip cells or principal cells will secrete the hormone, parathyroid hormone. Okay, and take note that the occiput cells, these are the supporting cells of the parathyroid gland, not seen at birth, and this will be formed 5 to 7 years after birth. Take note, occiput cells not present at birth. Okay. Ultimo bronchial body. The ultimo bronchial body will fuse together with the thyroid gland, and the ultimo bronchial body will form the parafollicular cells or the C cells. And again, it was mentioned during the orientation, the parafollicular cells or C cells will secrete calcitonin. Calcitonin. Okay. Some confusion here. Okay. Parafollicular cells is not seen at the parathyroid gland. Parafollicular cells will not secrete parathyroid hormone. What cell will secrete parathyroid hormone? Section B.
Chief cells.
Chief cells, very good. Okay. And what cell will secrete calcitonin? Parafollicular cells. Questions here? Questions po? Okay, if we have none, let's proceed to the adrenal gland. Okay. Adrenal gland has two layers, cortex and medulla. Take note, two layers coming from two embryonic origins. Cortex derived coming from the intermediate mesoderm, while medulla is derived coming from the neural crest cells, ectodermal in origin. Again, ectodermal in origin. Okay, when we go to the process of nervous system development, it will be mentioned, this is the neural crest. Okay, and one of the derivatives of neural crest will be the chromatin cells of the adrenal medulla. Neural crest, okay, coming from ectotherm, chromatin cells of the adrenal medulla. Okay, and earlier during our lecture in the development of reproductive systems, we did mention, diba, the intermediate mesoderm will give rise to the urogenital ridge. Okay, and adrenal gland is also derived coming from the intermediate mesoderm, specifically the adrenal cortex. Adrenal gland, again, two layers, cortex and medulla. Okay, cortex, we have a code to remember, GFR, glomerulosa, fasciculata, reticularis. Okay, late fetal period, the cortex will differentiate in the zones, but please take note, at birth, only glomerulosa and fasciculata layers are present. Again, only glomerulosa and fasciculata layers of the cortex are present. Zona reticularis will be seen 3 years after, formed 3 years after. Okay. Again, so you have the cortex and the medulla, newborn. Okay. The cortex is made up only of 2 layers. Okay. So what layers are present again at birth? So you have your glomerulosa and fasciculata. Reticularis will be seen 3 years after. Okay. In histology, again, go back to the secretions. Okay. So you have glomerulosa secreting your mineralocorticoids, aldosterone, fasciculata secreting more glucocorticoids, cortisol, while reticularis secreting more androgens. Okay, this is just a mnemonics. Okay, GFR. So you have salt, sugar, and androgens, sex. This is just a guide. Okay, huwag niyo naman masyadong dibdibin, di ba? Joke lang yan. The deeper you go, the sweeter it gets. Totoo ba yun, Dr. Roy? Dr. Roy, where are you? Dr. Reyes, totoo ba yun? Tinulugan na ako ni nag-thumbs up lang si Doc Chan. Okay? So these are congenital anomalies of the adrenal gland to remember. Ectopic. Where is the most common location of ectopic adrenal gland? Okay, fused to the kidney or seen on the right lobe of the liver. Those are the two common locations of ectopic adrenal gland. Okay, again, go back to the clinical entity, congenital adrenal hyperplasia. We did mention that earlier, diba? Caused by mutation of genes. Okay, so you have here increased androgen production during the fetal life. Okay, in females, again, it leads to masculinization of the external genitalia. So the newborn female can be mistaken as male because you have masculinization of external genitalia. And in males, if you have congenital adrenal hyperplasia, it leads to early development of secondary sexual characteristics. Okay. When you go to your physiology of the endocrine system, you're going to, okay, understand clearly the presentations of endocrine problems. Okay. So this is an example of congenital adrenal hyperplasia. Again, in females, it causes masculinization of the external genitalia. There is excessive androgen production seen during the fetal period. Okay, so this is just a picture. Okay, so you have pseudo hermaphroditism. Okay, internally, the features are that of female, for example, but externally, the features are that of male. Okay, pancreas. I hope you still remember our lecture in the development of digestive system. You have your dorsal and ventral pancreatic buds, okay, also coming from endoderm, the germ layer of origin coming from the endoderm of the foregut. So you have your dorsal and ventral pancreatic bud, dorsal and ventral, okay, formed during the 5 to 8 weeks of human development. The ventral pancreatic bud will form the head of the pancreas, including the uncinate process, while the dorsal pancreatic bud will form the remaining parts of the pancreas, including the head, the body, and the tail. But majority of the head of the pancreas derive coming from the ventral pancreatic bud. Okay, again, it was mentioned already, the histology of the pancreas. Okay, two main cells to remember. You have the beta cells and the alpha cells. The beta cells will secrete insulin. Insulin secretion will begin at 10 weeks, while glucagon secretion beginning at 15 weeks of human development. The pancreatic islets represents the endocrine part of the pancreas. These are congenital anomalies to remember for the pancreas. Okay. Agenesis, failure of development. Okay. And then annular pancreas. Annular pancreas, there's abnormal fusion leading to duodenal obstruction. And ectopic pancreas location, stomach, duodenum, jejunum, ileum, and go back to this clinical entity, Meckel's diverticulum. Okay, remember when we discussed this clinical congenital anomaly, there is bleeding, Meckel's diverticulum. The bleeding is a result of ectopic gastric or pancreatic cells in ileum. Okay, that's why you have bleeding. So here is a picture that will help you to remember again the formation of the pancreas. This is your dorsal pancreatic bud, ventral pancreatic bud. So look what will happen. There will be rotation. The ventral pancreatic bud will rotate to fuse with dorsal. Okay, and what are the derivatives again of the ventral pancreatic bud? Majority of the head and the uncinate process, while the dorsal pancreatic bud will form the tail, the body, and also the head region. But majority of the head region coming from the ventral pancreatic bud. Okay. Congenital anomaly to remember, a bifid. The problem here is the development of a biped ventral pancreatic bud. So here, bifid pancreatic bud. One rotates anteriorly, the other one rotates posteriorly, and after rotation, after it fuses to the dorsal pancreatic bud, what will happen? Annular. So it encircles the duodenum. Okay, so it forms a ring, a pancreatic ring that will encircle the duodenum, and this will mimic, okay, complete obstruction or partial obstruction of the duodenum. Questions about pancreas?
None po.
Okay, very good. Ectopic pancreas. So again, location, duodenum, jejunum, ileum. In the congenital anomaly, Meckel's diverticulum, which is a remnant of the yolk sac. One of the presentations again, blood and stool. And the bleeding is a result of ectopic gastric or pancreatic cells. Okay, last organ will be the pituitary gland and ectodermal in origin, but different sources. Oral ectoderm and neural ectoderm. The oral ectoderm will give rise to the glandular part, anterior pituitary gland, otherwise known as adenohypophysis, while the neural ectoderm will give rise to the nervous part, posterior pituitary gland, otherwise known as neurohypophysis. Okay, the oral ectoderm arises from the roof of the developing stomodium, hypophyseal pouch from the roof of stomodium, and we call it as Rathke's pouch. While the neuroectoderm coming from the neurohypophyseal bud from the floor of the diencephalon. Okay, again, let's have a picture to remember that. So here, this is the developing mouth, this is the developing brain, diencephalon to be specific. From the roof of the primitive mouth, roof, okay, upgrowth from the roof of the primitive mouth, you have the development of Rathke's or hypophyseal pouch, which eventually will become the anterior pituitary. Okay, from the neural ectoderm, a downgrowth from the developing diencephalon. This will form the posterior pituitary gland. Okay, a downgrowth from the developing diencephalon. We call it specifically as infundibulum. I'm sure this was mentioned in the orientation. So Rutgers pouch, you associate it with anterior pituitary, while infundibulum, you associate it with posterior pituitary gland. Okay, what are some clinical entities to remember? Ectopic posterior pituitary gland. Okay, usually the pituitary gland is lodged in the sella turcica. Sella turcica in anatomy is a depression seen at the sphenoid bone. Sphenoid bone. Okay, so this is sphenoid. Okay, so you have a depression here. This is where the pituitary gland is lodged. So you could have an ectopic pituitary gland. So here in the sella turcica, okay, pituitary gland, posterior pituitary gland is ectopic. So pituitary gland is ectopic. Okay, agenesis means there is absence of formation of the pituitary gland. Okay, so here, this is the stomodium, the roof of the developing mouth. Normally, you should have an upgrowth. Okay, and from the floor of the diencephalon, normally you should have a downgrowth. So pag nag-combine po yan, this will become your pituitary gland. So agenesis means there's no formation of pituitary gland. Okay, when you say pharyngeal hypophysis, there's a remnant or a stalk of the hypophyseal diverticulum in the roof of the oropharynx. So here, pharyngeal hypophysis. In rare cases, you could see duplication of the pituitary gland. So you could see here that two pituitary glands are present. There's duplication. And lastly, you could have a congenital tumor of the pituitary gland. We call it as craniopharyngioma, wherein a tumor arises coming from the remnant of Rutgers pouch. So again, pituitary gland, two parts, anterior and posterior, coming from ectoderm, but coming from two different sources. Oral ectoderm will give rise to anterior pituitary, while neural ectoderm will give rise to posterior pituitary. I think this is the last slide. Okay, yes. Okay. Questions po? Section B, questions?